following program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.
Hello, I'm Carl Seidel, host of The People's View. The People's View is a show sponsored by the Nashua Republican City Committee. The committee meets every second Thursday at the Crown Plaza. And if you want to contact us, we have a website, nashuagop.org. And at the end of the show, you'll see some contact phone numbers or email addresses that you may want to send us your comments and recommendations. Thank you for listening in.
Welcome to The People's View, a program dedicated to discussing local, state, and national issues and their effect on the American people. The People's View provides a platform for state representatives and national figures to present their viewpoint. Whether it's social, economic, or financial topics, you'll hear it on The People's View.
Our guest today is Charlie Arlinghaus from the Josiah Bartlett Center at St. Anselm's. And Charlie, why don't you tell our audience a little bit more about the Josiah Bartlett Center and how you, communicate with your people who are interested?
Well, if anybody wants to find out more, they can go to our website, which is jbartlett.org, jbartlett.org. We're a free market think tank.
Mm-hmm.
We examine state policy issues and whatever the state government is up to. We communicate on our website. You can sign up for an email newsletter that we do up there. I have a weekly column in the Union Leader. And we have, we have 3 websites. We have the Bartlett Center website. We have a site we maintain that's essentially a transaction register of state government, nhopengov.org. And then the third site is New Hampshire Watchdog, which has been a little less active because the guy running it for us is now has another job now, so that's a little less active. But that will be there'll be more there soon. But essentially, if the government is up to it, then we're looking at it.
I see. Well,
we exist. I should add, we exist solely from private contributions, and anybody who likes what we do can send us money. And there's ways to do that on the website, and feel free to do so.
Okay, remember that, because if you've read any of Charlie's articles, you really appreciate some of the background work that you do. I know I appreciated some of your economic talks when we went over the budget up when I was in the legislature.
Well, the budget was a mess back then.
Yeah. Well, it looks like it might be a mess coming up. Tell us about this big Medicaid, whatever you want to call it.
There are a lot of different names for it, but the state has something they call a Medicaid enhancement tax, which they've had for 20 years. And this has the potential to be a $400 million budget problem. So this could be the fish that ate Pittsburgh or something like that. The state, essentially what the state does is we tax, for about 20 years we've been doing this, where we tax hospitals, essentially everything they do that's medical. That money goes to the state, and we used it as a way to leverage federal money. Some people called it a scam, a legal scam, but a scam, where we would tax the hospitals and then give it back to them. But what we would technically do is we would take half the money we tax them under the Medicaid enhancement tax, give it back to something, give it back, half of it back to them, put half in the general fund, but the feds would match the half that we gave back to them. So the hospitals got dime for dime what they gave us.
Yeah.
So no big deal to them. They didn't mind, because they would, in fact, many years they paid the same dollar amount on the same day as the check they got, so they weren't ever out money. And we used it to leverage sometimes $100 million a year from the federal government. It's about 75 right now. We changed that. Over time, it got tweaked a little bit. More recently, in budget crises, it got changed a lot so that they weren't getting back what they were paying in. At that point, it becomes a real tax. And the hospitals say, wait a minute, if you take 200 and give us 200, we don't care at all what you're doing. But when you do this, it has to meet the rules and regulations. So they sued. And they sued under the guidelines that under our state constitution, you can tax anything. You can tax most things anyway. But you have to tax them fairly. So for example, if you were to tax a cup of coffee. You can't say, we're going to tax coffee if you buy it at Starbucks or Dunkin' Donuts, but not if you buy it at Cumberland Farms. You have to tax it equally everywhere. And what we're doing right now is we're taxing certain medical procedures, but only if they're done in a building called a hospital. And if the same procedure is done outside of a hospital, you don't pay a tax on it. So they sued. The court looked at it and said, yeah, that's unconstitutional. And it's kind of hard to argue with them. It's kind of a no-brainer. Well, the amount that they pay, we use some part of what they pay for the general fund and just spend on anything. We use some of it and pay specifically for part of the Medicaid program. And then a very small portion of it we use to reimburse them for unreimbursed expenses, and the federal government matches that. The total negative impact of the state budget is about $200 million, depending on a couple tweaks here and there, but let's call it $200 million. So over 4 years of a budget, or over two-year budgets, over two budgets, I should say, geez, it's $400 million. So what's going to happen next? The state, because they don't know what to do, and I'm not sure exactly what to do, the state's going to appeal. The appeal will put it off for maybe a year, but certainly until after the next election. So if you're an elected official today, somebody else has to deal with this after the next election, unless you happen to get reelected. So it's what legislators, I think, do best, is they, some legislators do best, is they punt.
What if they expanded the tax to include everybody that does that, not just hospitals?
So if, for example, every blood test done, no matter where it's done in the state, were included, or every knee replacement, or every, pick something, they could do that. The difficulty with that is when you did it with hospitals, it was a fairly easy tax, more or less, to administer. Hospitals are keeping track of these things anyway, and they can figure it out fairly easily, and you end up having only 26 taxpayers around the state. You would increase that number to probably hundreds of taxpayers around the state, hundreds of businesses, some very small businesses for whom it's a significant regulatory burden. If they're going to keep the tax, though, that's what they have to do. They have to expand it to everybody. I think most lawmakers would like to try to avoid that, because they don't want to create a whole bunch of people, they don't want to add taxes to a whole bunch of people right now who aren't paying them.
Sure.
That wouldn't be very popular.
Well, let's just add that the person who gets the screw at the end is the guy who's the patient.
Well, at the end of the day, it adds to our
insurance
healthcare
companies,
costs. Yeah,
sure.
The insurance company, and it just all adds into the churn in the system. I think at the end of the day, it's hard to know exactly what they should do or where they can go with it. I think what's going to have to happen is the principles of state government. Maybe it's the governor, the speaker, and the Senate president, or their budget proxies need to sit in a room at some point with some subset of the hospital industry and say, all right, what can we do? What can we do to change the system? The hospital was supportive of it when they were getting the money back. But when you stopped doing that, it was about a $250 million hit to the hospitals, and that's when they got upset. And so you probably need to try to go back to something like the status quo in 2008 or 9, although that may never be possible again, because then you layer on top of all this, you layer in all the changes that are being made through the Obamacare or ACA law that was passed, and that whole program might go away in its entirety.
Well, what about the expansion of the Medicaid? I mean, how does that get thrown into the mix?
It's a good question. And so if you think of this, the old system as having two components, the hospitals pay a tax, which is called Medicaid enhancement tax. And they receive back what's called a disproportionate share payment. Technically, that payment is for, hospitals are theoretically losing money on two things. One is the number of people they treat who don't pay anything, what's called uncompensated care or charity care. So they lose money on that. In theory, the expansion of Medicaid, they think will allow some of those people to pay money. Technically, the disproportionate share payment that comes from the Medicaid enhancement tax is designed to make up for the underpayment for Medicaid services. So Medicaid pays something like 40 cents on the dollar. What the full charge is, it's hard to decide. but it pays less than it costs significantly in New Hampshire. I think we're one of the lower in the country too. And so theoretically, that's to make up for that. If you're a hospital that has a disproportionate share of Medicaid patients, it's very difficult for you to stay in business. And so we make up for it that way. So that layers on that. Frankly, I think part of the reason some people in the legislature were very gung-ho on Medicaid expansion, which and I was not, but the reason some of them were was because they knew the hospitals had taken this this hit of hundreds of millions of dollars in the past, and they said, all right, let's do something to help them.
Does that really help them?
It's very hard to say. I mean, certainly they think they do. So you get a whole bunch of new patients in, and if everybody coming in used to come in and wasn't paying money before, then yeah, it helps you because you're just getting a partial payment for people you used to get no payment for. But the experience of states that have expanded Medicaid, and there were a whole bunch of experiments associated with Oregon doing this and testing this group versus that group. And it seems to be that there's a lot more utilization of service. And so if you're losing money on a Medicaid patient, then you're losing more money because they're now doing more services. And although there's some people who argue that that's an open question. Are they really losing money on Medicaid patients?
Well, there was a caveat, I guess, in the legislations, I remember, that if they don't, if the government doesn't give some kind of waiver to certain, then they stop this. Now, I can't really picture them starting something, letting it go for 2 years, then trying to say, sorry.
It's difficult to expand a program to 50,000 people or 80,000 people, depending on what your estimate of the number is, and then cancel it. Technically, under the law, the program does in fact go away, period, at the end of 2016. It goes away anytime before that if the federal government does not pay 100% of the expansion costs, whatever exactly that is. But we're going to have this debate again in a year and a half.
You know, one thing I never understand, most of this uncompensated care is in the emergency room, isn't it? Or
well,
not?
a lot of it is, yeah. People who use the emergency room for, people use the emergency room and don't have insurance.
Sore throat or whatever. Why don't they have a urgent care part, you know, that doesn't have all the overhead attached to the emergency room?
It's a good question. A lot of hospitals are moving toward that and are starting to partner with other organizations. So in some large cities, for example, there are partnerships forming between the hospitals and community health providers who basically exist to provide for uninsured and underserved populations. And they're developing that. The difficulty is that a lot of the patients who use the emergency room for, let's say, non-emergency care, they know about the emergency room. They know to go to the emergency room, and it's easy for them, and they know of it. And to divert them to a less expensive facility, you have to divert them to a facility they actually don't know about. And so there's an education component there that's also very expensive. But at the end of the day, that's probably one of the solutions is to take people. You want people treated in an appropriate setting. I mean, for some people, you need to go to the emergency room. It's an emergency.
Yeah. The heart attack.
Frankly, if you think you're having a heart attack, even if you didn't, I'm okay with that. You went to the emergency room and you weren't having a heart attack. Yeah, but you thought you did. You thought you were, and you were wrong. Better safe than sorry. I'm okay with that. But we need to transition out of that process. So.
Well, some of these pharmacies now are starting some kind of a care unit with them. How is that going to fit into the future?
Well, it's a good question. There are a lot of things we go to the doctor for. We go to the doctor. You know, you used to think the world as you're a little bit sick, you go to the doctor. You're really sick, you go to the hospital, and that's the way the world worked. Now there's a continuum of care in between. Many of these, one of the brand names is Minute Clinic, or sometimes they're called convenience clinics. And they're often staffed not by a doctor, but by a nurse practitioner who's almost a doctor. You don't want them doing heart surgery, but for most things, when I go to my primary care doctor, I more often than not actually see the nurse practitioner. You go there and for flu shots, or you've got the sniffles, or some basic
Ear
things.
infection or
Yeah,
something
exactly.
like that.
It's sort of an obvious place to go. You don't need an appointment. It's convenient. It's on the spot. They're in pharmacies. For a while, some department stores like Target, for example, were opening them up. I don't know if they aren't around here yet, but in some parts of the country they are. And it's convenient because you're doing something else and you're going to be there anyway, if the grocery store, the drugstore, whatever. And I think it makes a lot of sense. If you have, like for a flu shot, why should you make a doctor's appointment? You don't need a doctor's appointment. And there's a whole bunch of things that you could have done that way. I think that saves the whole system money. It allows doctors to see more patients that they need to see, as opposed to the patients that maybe they don't need to see. And we could divert to a nurse practitioner is going to be a less expensive use of care than a doctor is, and that's good for everybody.
Oh yeah, yeah. I think that can be done. I mean, the flu shots and other shots.
Certainly
like
flu
doing
shots,
now.
but frankly, most of the things that are wrong with you that aren't complicated are easy. If you've in allergy season and all that kind of stuff. Frankly, 9 times out of 10, when I go to the doctor, it's allergy season. I kind of know what's wrong anyway. The exact same thing happens and has happened for 20 years. They give me a very specific prescription. I get an albuterol inhaler. I know that's what's going to happen. I can chart the whole thing out in my head, but I have to do that because you can't just get those over the counter. And in a situation like that, I probably don't need to tie up the doctor.
Well, we'll see what happens up there. It's going to be an interesting time, that's for sure.
It is. The legislative session is always fun, and then we cross right over to election season.
That's right. Well, one of the other things that when I was there, I wasn't on the Health and Human Services, which I think, what does that have, about 45% of the budget or something like that?
It's a big chunk,
It's a big chunk. I went to a few of the committee meetings, and what bothered me is I don't ever see any really digging into the work that they shift out to some of the non-profit organizations. Are they getting something for their money? How do we determine that? I don't see that recognition in that particular agency.
There's been some discussion lately about, and it's a double-edged sword, right? I mean, there's part of you wants to do as much as possible in-house, if you will. On the other hand, there are a lot of things that it makes perfect sense to contract out for. And it's, we understand that in snow plowing.
Yeah.
Nothing wrong with hiring a guy who has a snow plow to plow your roads. And in healthcare, you don't hire just anybody with a plow on their truck per se, but what you are hiring is, in some cases, is a specialized agency and you use them. To what extent in government, this is a problem all over state government, I think, in any government, is we do what we did last year, and that's what we start with. And we tweak off of that, up or down a little. And if we've always farmed this out to this organization, we tend to do it again. I know at the end of his tenure, Governor Lynch made a lot of noise about the number of agencies HHS contracts with. And there were something like 3,000, I think he said, nonprofits. And they wanted to kind of pare that down a little bit.
Get them to join together.
Get them to join together. If you have 2 people who can partner. I don't believe in lowering the number just to lower the number, and it could make sense. On the other hand, if the reason you have a lot is because the person doing this in Nashua and the person doing it in Manchester are 2 different agencies, it doesn't help me if they just merge and are the same agencies with the same people, but just have technically one corporate structure. So you have to work with that a little bit.
Well, I think you can do that if you evaluate the service. That's
sure.
I mean, even they talked about your snowplow example. They check and make sure the people are doing, how many times they're cleaning the roads that they're supposed to be cleaning, or are they doing somebody's parking lot, So, and if they catch somebody doing that, they're off. you know.
The great thing about snowplows is that if my road isn't plowed, somebody knows about it right away. Yeah, it's a good
right.
point about how are we measuring and all of that.
Right.
There was a state rep for a while, for many years, from Bedford, Ed Moran,
Oh, yeah.
who spent a decade or more trying to get the state to adopt metric programs.
Right.
And I don't mean kilometers and things like that. I mean some sort of
Right.
measurement metric
Right.
where you can't measure, you can't manage what you can't measure. And we need to make as much as possible measurable. And I think there's a reluctance inside of state government to make things measurable. And I think those of us on the outside or watching over them on some level need to push that a little harder.
Well, I think we have to, you know, apparently Lynch was starting something like that and organizing some communication between departments to make sure that they were following some sort of standard of going through this. But right now they don't really even follow the audit. We have an auditing department and they come in and they make, well, sometimes just processing procedures changes, but a lot of times they try to evaluate how effective or efficient they are, and they just don't follow their suggestions. So I think it really has to come down. Maybe we have to start legislation on that.
I think on some level, if you had, I mean, from my standpoint, a lot of this comes down to the governor. The governor is the chief, is the top management professional,
Right.
theoretically, in state government. And a governor who's interested, a governor who's strong and who wants to do something can make a big difference. You can, if you're the governor, you can hold your department heads accountable if you choose to. And I think the problem is in politics a lot of times, it's great to announce an initiative and people don't really track whether or not you followed through on it. And I think a lot of that could be done with management from the top.
Well, let's hope we can change it sometime.
I just want someone on some level who is interested in making them come up with metrics, holding them accountable for the metrics. And at that point, I think that would be a huge advance. Because we all then know something. We all then have an additional piece of information to say, what were we trying to do? Did we do it?
Yeah. And
Basically.
if not, what should we change? Or, you know, get rid of some of the programs that aren't really being effective. One other thing before we leave healthcare,
Sure.
that's a real question in the state, is the mental health program. Have you gotten into that at all?
I have. It's a very complicated issue, and there are lawsuits over it, and there's some very significant changes that are going to have to be made to it. But I think it's a topic unto itself, and how you deal with that area, and the changing nature of how we understand mental health today. It's very complicated and very specialized. So I don't think I have a lot to add to that. Without sounding trite.
But something I think you're right. It's complicated, but one of the things that I realized when I was in is that it was effective. These mental health judges, or I guess courts or whatever you called it, where they instead of putting a person and incarcerating him, they had him working with a non-profit organization who watched him to make sure he took his meds or whatever, and perhaps even had a place for them to live, because some of them are homeless.
I think it makes an enormous difference that the connection between mental health and the correction system is very strong right now. And I think that if you were to look at corrections in New Hampshire, prisons or anything related to it, that is one of the issues that if we incarcerate somebody, when we send them to prison, we now have a captive audience, so to speak, literally a captive audience. And one of the things that is incumbent on us, I think, to make society safer, to make society better, is to treat this person. If they're going to get out, and most of them are going to get out at some point, if you had someone in your custody for 3 years, you knew they had an issue that you could deal with, and you didn't, then that's the equivalent of malpractice. And I think we're starting to realize that more. We published a paper probably 15 years ago now, written by a defense attorney in Concord named Charlie Russell, who had seen this a lot. He had a lot of clients who he looked at them and he thought, you know what, when this guy was in last time, if somebody had worked with him, he wouldn't be here again on trial again, that we could have fixed this, and there were never the resources.
And one other aspect of this is the juvenile problem in that area. If you catch them early enough, you help them out, they never get into the terrible situations that they get into later on.
Well, that's a big thing, and I think we all know that inherently from our own experience with people. And there's a good bill this year, I think, that at some point we lowered the age at which you have to be tried by an adult, to 17. There's a bill this year to raise it back to 18. One of those few times when there's a bill that conservatives and liberals both agree on, and which I think is going to pass. I actually wrote about this in the Nashua Telegraph recently. Middle of April, and we would raise it back up so that some 17-year-olds would be tried as an adult, the serious crimes. But most of the crimes committed by 17-year-olds, 3% are felonies, and of the 3% that are felonies, only a small fraction of them are very serious felonies. Would those people be tried as an adult? Sure, absolutely, and the brutal cases we all read about. But in a lot of cases, you have someone at 17, the juvenile system is where they belong, where they can get the treatment they need.
Even now, it really doesn't, it's hard to get kids who are recognized maybe in the elementary schools as having a problem to get treatment, without, unless you have a very, very good health plan.
Yes, that's very true.
Well, let's go to something else in the last few minutes that we have.
Sure.
PSNH, and there's some thoughts of them getting rid of their production unit, and after we made them spend $1 billion to us.
It's a complicated issue, and it's difficult for a lot of people, but essentially one of the last vestiges of deregulation that wasn't changed is PSNH, unlike the other utilities, still owns some generating assets. Notably, a coal plant in Bow, but a number of other little plants. There's a bill, as there is every 2 years, to force them to sell them, to basically force divestiture, or in some cases to move it to the PUC, Public Utilities Commission, to decide. I've looked at this, and I've written about this now and 6 years ago as well. And there's a segment that says, let's just get rid of it. Let's get rid of the plant. We don't want them to have it. The way I look at it is we made them put pollution control equipment on it. Arguably the right thing to do. Pollution control is probably a good thing on an old coal plant. People don't like how much that cost. I think the final price tag is close to $500 million. If we force them to sell it, the deal is that we told the company that bought it, you put up the money and pay for it, and you can get return on your investment in your rates. And under that circumstance, they said, yeah, okay, we'll do that. So we still have to pay it off, whether the plant operates or doesn't operate. This winter, when electric rates were so high, the spot market was enormously high, and the coal plant operated almost all the time. And it saved PSNH ratepayers. I have units also immaterial to me. But PSNH ratepayers, it's about 2/3 of the state. It saved them more than $100 million. We have an asset that is almost paid off except for the scrubber, and we have to pay that off anyway. Right now, we know that price spikes are going to happen in the winter because we're at the end of the gas pipeline. We don't have enough cheap electricity to offset that. We don't have enough electricity that's cheaper than that it won't run. So don't sell it if you're saving money. And if we stop saving money, sell it. Okay.
Well, I think we've run out of time. I really enjoyed talking to you. We've got to have you back again. But people can contact you with the information that you mentioned early in the program, which we have at the end of the tape.
Great.
So thank you again.
Thank you, Carl.
Okay.
The preceding program was provided by an independent producer solely responsible for its content. The opinions expressed do not necessarily represent the views of this station, its staff, board of directors, or underwriters.